Brilliant, thank you very much. My name's Claire McCarthy and I'm the Learning and Development Manager for Childcare, and I'm pleased to be joined by Paul Boker, one of our quality training advisors in childcare, and also Eunice Vignier, our nursery manager for our Hackney nursery. So thank you to both of those for joining us this evening. So this evening's session is just one of the co-op conversations we're holding over this week, and is just one of the many different sessions that Mid-Counties will be running throughout the year. So please do visit our events page on our website to see what we have coming up over the next few months, so you can join us again as we cover different topics throughout the year. We would also love you to be posting throughout the event today and keep promoting our event. So either tweet us or post to our Facebook account. So please do tag us in any of the tweets or posts that you put on to your social media about our event this evening. In terms of today's session, so hopefully we'll make it as interactive as possible, but please do share your views, ask lots of questions. There are no right or wrong answers, and it's a really good opportunity for us to share a little bit about what we do in cooperative childcare and Little Pioneers. So I'm just going to stop presenting very briefly to fill you in a little bit about what we do. So welcome to this evening's co-op conversation on Learn Basic First Aid for Children. So at Little Pioneers, we take the security of our children in our care very seriously. Our number one priority is the welfare and well-being of our children. So we take every step to make sure that they are always safe and secure in a fully protected environment that's also fun and free for our children to explore. So the current Ofsted requirement for paediatric first aid trained colleagues in a nursery setting is at least one person who has a current paediatric first aid certificate must be on the premises and available at all times when children are present, and must accompany children on outings. And providers should take into account the number of children, staff and layout of premises to ensure that a paediatric first aider is available to respond to emergencies quickly. However, we wanted to go above and beyond this requirement so our parents could have that complete trust in us to keep their little ones safe and secure when they're in our care. So the Millies Mark Award certifies that all practitioners in a nursery setting are fully trained in paediatric first aid, and they are confident to deliver first aid if they need to. Millies Trust was set up by Dan and Joanne Thompson after their 9-month-old daughter Millie tragically died from choking on food while she was at the nursery she attended. So Millies Mark is delivered by Millies Trust in partnership with the National Day Nursery Association and is supported by the Department for Education. And the organisation now campaigns to increase those legal first aid requirements amongst childcare providers. So the Millies Mark Award not only requires us to have 100% of our practitioners trained in paediatric first aid, but they also need to be confident to administer first aid too. So as soon as we heard about the accreditation, we couldn't wait to be involved to ensure that we were being held to the highest possible standard to allow us to deliver the best possible care for our children. And we were the first large childcare group in the country to be awarded all of our nurseries with 100% Millies Mark accreditation, which we think is a fantastic achievement. So I'd now like to hand over to Eunice, who is going to tell us about what holding Millies Mark accreditation means to her, her team, and the parents who use her nursery. Over to you, Eunice. You're very quiet, Eunice. You might need to shout.
I will try and use my loudest voice. So when we heard that we had to do all the forms being I'm not gonna lie, it was a lot of work, but in the long run, I noticed that it enables us to assess the staff's confidence in delivering first aid. Because we do come across several accidents in the day. It can be minor things, but we touch wood, we don't want big accidents to happen, but these can happen as well, whether it's broken bones or a child that has something stuck in their nose or a child choking on food. So we do want to know what to do, and Millies Mark has enabled me to assess my staff confidence, see see who was confident to pair with the ones that were less confident, but also to put stuff in place to increase everybody's confidence. And yes, on our review paper, we have to talk about first aid and go through different scenarios. I try to create my own scenarios so the staff don't have the same questions all the time, so they kind of have to think about the box and not just give me the same answers all the time. But it does help them to go back into their knowledge and refresh their training. But also, what I do is at every staff meeting, and I have one every month, I go over different scenarios that can happen in the childcare and what should they do about that. So it helps everybody in a fun way to revise what they learn into their when they're doing their training, because the training is only every 3 years. And so I noticed that my staff has become more and more confident into dealing with any kind of accidents that can happen. Yes, for the big ones, they might just shout for me to come so I can deal with them. But the things stuck in their nose, the finger strap, they are able to deal with it and just report to me afterwards. And it helps as well with when sometimes we have agencies, they then do not have to worry about having to administer first aid, because every other member of staff that are a co-op colleague is first aid trained. And parents are then very impressed when I tell them that all of my staff is first aid trained, and that kind of reassures them, especially when I go into how Millies mark accreditation came to be. So hearing that a baby died because of choking, because there was not enough first aid on site, it reassures them to know that all of the staff in the co-op nurseries know what to do, and so we can take steps to prevent any kind of big accident to happen. And I can give you an example of how this has affected me personally. I remember before we were Millies mark accredited, I had my pediatric first aid, but I remember walking into a big hall where children were having breakfast, and a little boy was choking in front of me, was turning blue, and I literally froze. Didn't know what to do. Luckily, there was one area manager who managed to get hold of the child and do the 5 slap on his back, so managed to dislodge whatever was stuck in his throat. If that happens today, and it does happen, I don't freeze anymore because I've been through the situation. I've been through the training several times. My manager talks to me about different scenarios that can happen in a nursery, so I need to always think back. And the fact also that I have to quiz my staff on their knowledge, I have to keep my knowledge at the top, so they can't catch me on anything. And if they do, then it's good for me to go and refresh my knowledge on the first aid. So I think, although at first I was thinking it was a lot, I think in the long run I see the benefit definitely of us being Millies mark accredited, and I can see obviously that it does help not only the staff but also the parents, and having that confidence in us and leaving their children with us, because they know that yes, we'll care for their development and they'll be happy, but also if something happens, they know that they're leaving their children in capable hands. And that's it for me.
Brilliant, thank you, Eunice, and I'm really pleased to hear that you can see the benefit of that Millies mark accreditation and what impact that has on your team and your parents. So thank you for sharing that with us. So accidents to children are a significant health issue, being a major cause of preventable death, serious injury and long-term disability across the UK. So every year in England, 60 children under the age of 5 die from injuries in and around the home, which is 1 in 12 deaths of all children aged 1 to 4 years old. And there are also 450,000 visits to A&E departments and 40,000 emergency hospital admissions in England each year because of accidents at home amongst the under 5s. Under 5s are particularly at risk of being injured in home accidents, with falls accounting for the majority of non-fatal accidents and threats to breathing such as suffocation, strangulation and choking causing the highest number of deaths. So firstly, we're going to look at choking. So children can swallow, inhale or choke on items such as small toys and food items. Nappy sacks used to dispose of soiled nappies can also pose a risk to babies and young children, with babies suffocating after covering their nose and mouth with a nappy sack or choking after putting a nappy sack in their mouth. So babies and children are at most risk from choking as they explore their environment by putting things in their mouth. So we're now going to play you 2 videos demonstrating how to respond to a baby and a child who is choking. So I'm just going to share my screen with you to share these videos with you, and hopefully you'll all see them. Please don't panic if you don't get to see the videos your end, if the internet connection your end isn't strong enough, because we will post the links to the videos afterwards as well, so you will be able to watch them back at a later date, or you can watch the recording of the session on YouTube once it's been posted. So bear with me while I just share my screen. And we will go into choking.
Hi, so we're going to start off by doing choking. So choking for a child and choking for a baby. So the first thing that we would do is when a child or an adult is choking is we would ask them to cough. Because 9 times out of 10, if they can cough, they can get it out themselves without you needing to administer any first aid treatment. Choking is very serious and it is life-threatening, and it's something that does happen quite often, so we really need to get into doing the actual back blows and things like that as quickly as possible. Okay, so this mannequin is a child, so a child is categorized as a person between the ages of 1 and puberty. So choking. First thing I'm going to do is I'm going to ask them to cough. So are you okay? Can you cough? If they can cough, they might be able to bring it out themselves. If they can't cough or they can't respond to you, you're going to have to start getting into your back blows and things. So what we would do is, this would be a child. You would put them in between your legs like this and hold their body like that. And you want to use the heel of your hand into the middle of the shoulder blades. So it's really important that we're getting some really good force here. So whenever I do first aid training, I always try and make sure that I'm saying it's not a tap like this, it's a back blow. So think about an aeroplane landing. You're really going to get a good blow there. And we're going to do 5. We're going to do 5 back blows, and then we're going to do 5 abdominal thrusts. So what we do is, once we've done our back blows, we're going to check to see if it's come out. Has the thing come out? Are they still choking? If it hasn't come out, then you're going to do your abdominal thrusts. So get the child in between your legs again. So move them from this position to this position. Make a ball with your fist underneath the ribs. Hold your hand, hold your fist, and then you're going up and in, like this. So we're going to ask them if they're okay. We're going to do 5 back blows, and then we're going to do 5 abdominal thrusts. And you're just going to repeat that until the thing eventually does come out. So just a quick demonstration. Are you okay? Are you choking? Can you cough? They can't reply, they can't cough, so you're going to go into your back blows. Really need to make sure in the middle of the shoulder blades, the heel of your hand. So 1, 2, 3, 4, 5. Check to see if the thing's come out. If it hasn't, then you're going to do your abdominal thrust. So 1, 2, 3, 4, 5. And like I said, what you're trying to do is, this is going to give enough force to get the thing out, and this is going to kind of squeeze the insides and hopefully loosen whatever it is. Okay, thank you.
So that was for a child, and then we're just going to go into the video for how to respond to choking in a baby. So hopefully it will load very shortly. Buffering at the moment. Oh, sorry, there we go.
Hi again. So we're going to do choking for a baby now. So obviously you're not going to ask a baby if they can cough and if they're okay, because they're probably not going to respond. But what you are going to be looking for is, are they gurgling, are they crying, are they making a noise and things like that. They may be flailing their arms around, the face maybe going like a redder colour and things. So what we're going to do is, we're going to do exactly the same for a baby, but we're going to hold them on our arms like this and in between our legs. It's really important that you're using the thumb sorry, the thumb and the finger to hold the neck like this, so that obviously the baby's you don't hurt the baby, basically. So what you do need to do is make sure that the baby's bum is above the head and you're holding the jaw open to make a really smooth airway. And again, you're going to use your fist and do the back blows. So you're going to do 5 like this. Remember, it's all about making sure the aeroplane's landing rather than doing soft taps. You want to get some good pressure and some good force there. Then what we're going to do is we're going to check the baby, see if the things come out, see on the floor has it come out. If it hasn't, you're going to do abdominal thrust for a baby as well. So again, put the baby on your arm like this, legs apart with your arm, and you're going to use your thumb and your finger to hold the baby's head in a nice position. 2 fingers under the rib cage and just 5 abdominal thrusts. So just to demonstrate, baby's choking, I'm checking if they're crying, checking if they're making a sound, I'm looking at the skin colour, things like that. So I need to do my back blows, so I'm going to be really careful not to hurt my little baby. And we're going to do 5. So bums in the air, 1, 2, 3, 4, 5. Check to see if it's come out. If it's not come out, then you're going to do your abdominal thrusts. So 1, 2, 3, 4, 5. And you would just repeat until the thing does come out. Thank you.
Let me just stop sharing my screen briefly. Thank you, Paul, for recording those videos for us. They're really, really good. So I'm just going to go back to the presentation very shortly. So to help prevent a baby or child from choking, there are some things that we can do to help them prevent ever being in that situation. And these things include things like choosing toys that are appropriate to the age of the child, ensuring that small objects such as marbles, peanuts and small toys are kept out of reach of children under 3 years old. Encourage those older children to keep their toys away from their younger playmates. Keeping those nappy sacks out of the reach of babies and young children, and storing them, never storing them around the cot or the pram where the child can easily get access to them. And with small foods such as grapes, cherry tomatoes, blackberries and other soft fruits, they should be cut into quarters to prevent the child from choking on those. And we do have a chopping guidance in all of our nurseries, so all the food that's prepared for the children in our care does adhere to the chopping guidance for the age of the child to help prevent children from choking on the food whilst they're having their meals with us. Okay, so now we're going to move on to poisoning. I'm going to put my PowerPoint back up and move on. So poisoning, most poisoning accidents involve things like medication, household products and cosmetics, and some poisoning agents can cause breathing difficulties. So more than 28,000 children receive treatment for poisoning or suspected poisoning every year. And poisons can be described as any substance that causes damage when it enters the body in sufficient quantity. So a poison can enter the body in 4 ways. So it can be ingested, which is when it's swallowed. It can be inhaled, which is when it's breathed in, entering the bloodstream very quickly as it passes through the lungs. It can be absorbed through the skin, and it can also be injected through the skin directly into tissues or into a blood vessel. And a poison can be either corrosive, such as acids, bleach or ammonia, or it could be non-corrosive, such as tablets, drugs, alcohol, plants or perfume. So to treat a child who has been poisoned by a corrosive substance, you need to make sure, firstly, as Paul will mention later on when we talk about our Dr. ABC, you need to make sure that you don't endanger yourself. So you need to make sure it's safe for you to help that person or that child. You need to dilute the substance or wash it away if possible. So substances on the skin you can wash away with water, and swallow substances. So if the child can swallow and doesn't feel sick, then you can get them to rinse out their mouth and then give them frequent sips of water or milk. You would call 999 for emergency help and give information about the poison if possible, and take advice from the operator. If the child becomes unconscious, then you need to open the airway and check for breathing, and resuscitate if necessary using a protective face shield, because we don't want you then to become poisoned by the substance. If the child is breathing, then you would place them into the recovery position. But it's really important to make sure that you never make the child vomit, as this may put the airway in danger. For a non-corrosive substance, you would call 999 for emergency help and give information about the poison if possible, and take advice from the operator. So if the person becomes unconscious, open the airway and check for breathing, and resuscitate if necessary using that protective face shield again. And if the child is breathing, then place them into the recovery position. It's really important that you don't shout at the child for taking any substance or being poisoned by any substance, as they might become frightened and they are then unlikely to tell you what they've taken. But it does help the paramedics if you can pass on any containers or information about the substance, and also find out how much has been taken and when it was taken. And if the child does vomit at all, then you do need to keep some of those samples of any vomit so the hospital can do that analysis at the hospital to help that treatment of the child. So to help prevent poisoning in children, it's really important to keep your medicines and chemicals out of sight and out of reach of children, preferably in a locked cupboard. So wherever possible, buy those products in child-resistant containers. Always store chemicals in their original containers, because if anybody does become poisoned by any substance, having that original container will help the hospital give the right treatment to that person. Make sure you dispose of any unwanted medicines and chemicals safely, and avoid buying plants with poisonous leaves or berries, or those that could irritate the skin. So I'm now going to hand over to Paul, and Paul is going to talk us through the treatment of burns and scolds.
Hi everybody, thank you for that, Claire. Yep, so like Claire said, I'm going to talk about burns and scolds. Let me just, so many of the children that do actually go to accident emergency with a burn or scald are referred for further hospital treatment. It's kind of one of them things that's not just going to disappear, it does need further treatment. There's lots of things that can obviously cause like burns and scalds, hot drinks being the biggest common denominator one. So hot drinks cause most scalds to children under the age of 5. A child's skin is much more sensitive than an adult's, and a hot drink can still scald a child 15 minutes after being made. Young children are also very vulnerable to sunburn. Hot bath water is responsible for the highest number of fatal and severe scalding injuries among young children. Around 500 children, mainly under 5s, are admitted to hospital, and a further 2,000 attend A&E departments every year as a result of bath water scalds. Other bits and pieces as well. Children can obviously suffer burns after contact with open fires, cookers, curling tongs, hair straighteners, cigarettes, matches and lighters, and things like that. So some really good tips to kind of prevent the risk of children getting burnt is not holding hot drinks whilst you're holding a child, so not doing both at the same time. Not leaving young children alone in the bathroom so that they can't maybe play with the taps and make that bath water warmer than it was. Putting hot drinks out of reach for children so that they can't grab them. Encouraging the use of a coiled flex or a cordless kettle. Keeping small children out of the kitchen whenever possible, though I can probably see that's not the easiest thing to do all the time. Run the domestic hot water system at 56 degrees, or fit a thermostat mixing valve to taps. When running bath water, turn the cold water on first and bring the temperature up rather than doing hot water and then cold in. And test the water temperature using your elbow. It's a good little tip. Always use the rear hot plates if you can when you're cooking on your stove, and keep the pan handles turned the opposite direction so children can't grab them. And I know this from my many female friends, is keeping hot irons, curling tongs and hair straighteners out of reach of babies. I know lots of little accidents that have happened in that way, even with my friendship group. And yeah, if a child sustains a burn, we need to kind of assess the severity of it. So I think Claire's got some pictures for us to have a look at.
Yep, I've just moved the slide there.
Yeah.
Let's go.
That's perfect. Thank you. So firstly, what we do is we look at the size of the burn. You need to seek medical advice for any size of a burn with a child, whereas for an adult, any burn that's larger than 1% of the body area, that would require hospital assessment. And that's around the same size as the palm of the casualty's hand. We need to look at the cause of the burn. Some common causes, like we've kind of already spoken about, you've got dry heat, wet heat, radiation, chemicals and electricity. Then we need to consider the age of the casualty. Like we said, for children and elderly people as well, we would seek a medical advice for any sort of burn. Then we need to have a look at the location of the burn and where it is on the body. Burns to the face, hands, feet, genitals, or burns that go all the way around a limb do need hospital treatment. And we then need to assess the depth of the burn. So all full thickness burns should be treated in hospital, but to seek medical advice if you're unsure. And I think we've got, this is going to explain what full thickness is. So many of you might already know this. I imagine most of you do. The skin has 3 layers. You've got the epidermis on the outside, the dermis beneath that, and then the, subcutaneous. I tried my hardest. I've done subcutaneous fat. The depth of burns can be defined as a superficial one would be burns only to the outer layer, and that's often caused by hot water, things like that. It might look red, sore, maybe a little bit swollen. You've got partial thickness, which burns both the epidermis and the dermis layers of the skin, and that can often look really raw, and that's where you might get blisters forming. And then you've got full thickness, burns through all 3 layers. I'm trying not to say that word again. The burn may look pale, charred or waxy, and the nerve endings will be burned away, so pain in this area may be absent, misleading you and the child into thinking it's not as severe as it actually is. How do we treat burns? And these are quite common. So what do we do? We're going to cool the burn down if we can. So we're going to use cold running water for full 20 minutes. And trust me, I have worked with children my whole life. I know how hard it is to get them to flush it out with the water on the tap. Immediately cooling it is best, but it's still beneficial even if it's a little while after the burn, if you haven't identified it and things like that. And avoid hypothermia. So cool the burn, but warm the rest of the casualty, especially the elderly or children. Removing jewellery and loose clothing. So do this as gently as you can and as carefully as you can before the area starts to swell. Don't remove anything that is stuck to the burn. So if you've got clothes or plasters or anything else, don't take them off. Leave them where they are. And for burns that involve chemicals, be careful not to contaminate yourself or other areas of the body. Claire was talking about danger in Dr. ABC earlier. That's really important that you keep yourself safe. And cover the burn. So we would cover the burn with something that doesn't stick. I know probably I often get asked if we use is it cellophane? We wouldn't use that, no. Cling film is ideal. Discard the first 2 turns of the film just to make sure that it's nice and clean. Alternatives could be a new plastic bag, a low adherent dressing, or a clean lint-free cloth. And if the burn appears severe or the child has breathed in smoke or flames, obviously call 999 for emergency help. And just a few bits and pieces that we wouldn't do. We don't cool the burn using ice. We don't burst the blisters. We wouldn't touch the burn, only around it. Probably wouldn't put creams on, ointments or any sort of fats. Apply adhesive dressings, we wouldn't do that. And we wouldn't remove clothing that has stuck to the burn. And I think we're back to Claire for bleeds.
Brilliant, thanks, Paul. So yes, so to treat a child who has a bleed, we need to follow these few steps here. So we would sit or lay the casualty down, so making sure it's appropriate to the wound location. So wherever you sit or lay the casualty down, make sure you can still get to the wound where they are bleeding from, and make sure they feel comfortable. We need to examine the wound to see what type of bleeding it is and if there's anything in it. So if there is something in it, we wouldn't remove that from the wound because that could make the wound worse. So we would need to apply the pressure around the object or the thing that's embedded in the wound to make sure we can still get pressure to that wound. We would then apply pressure to the wound continuously for 10 minutes, and that is to start the clotting motion in the wound, which will help stop the bleeding. And then we would apply a sterile dressing, applying a second one if the first one becomes soaked through with blood. What we would do if the second one then becomes soaked through with blood is we would take both dressings off and restart the dressings because the first one may not be effective enough to stem that flow of blood. But our aim with bleeding is to make sure we can stop that bleeding, reduce the person from going into shock, and also prevent that person from getting any kind of infection from their wound. Okay, so we're going to move on to febrile convulsions. So the area of the brain that regulates body temperature is not fully developed until around 4 years old. So if a child develops an infection, this can lead to the core temperature of the body quickly rising. So the word febrile means related to fever, and indeed febrile convulsions are nearly always triggered by the child's temperature rising rapidly, usually above 38 degrees Celsius. So a febrile convulsion can be very frightening, and during the seizure the child may appear to stop breathing and the lips may go blue. So therefore it's important that the person dealing with the seizure needs to remain calm and offer reassurance. Febrile convulsions mostly commonly affect children between the ages of 1 and 4, and they affect around 1 in 20 children, but they can affect children anywhere between the ages of 6 months and 6 years. And the child may have been unwell over the past day or so, will be hot to touch. So you may feel the temperature rising just from touching the child. So to treat a febrile convulsion, we need to make sure we remove the clothing and bedclothes to cool the child down, and we loosen any tight clothing around the neck so that we reduce the risk of strangulation while they're having their seizures. We also need to try and protect the child's head with hands or coats, but it's really important that we don't hold the head still. So you wouldn't want your hands touching the head either side. You would just want them slightly to the side. So as the child is having the convulsion, your hand is protecting them, but we're not holding them in place because this could then cause damage to their neck and cause further damage. It's important to time the seizure duration. So when you phone 999, they are aware of how long that seizure has been taking place. So we would cool the child down using tepid water. And what's really important is we don't rapidly cool the child down because that can lead to the child going into shock or into hypothermia. So gradually cool the child down using that tepid water. We wouldn't use freezing cold water. As I said, this could take the child into shock. We'd remove any hazards that the child could come into contact with. So if there's any furniture or resources or anything that they could injure themselves on near them, then we would need to make sure we move those hazards out of the way. We would always move the hazards, not the child. We would leave the child having their seizure where they are. As I say, you would dial 999, and it's really important that you continue to monitor their airway and breathing, because if they do stop breathing, then you would need to open their airway and start administering CPR to support the child. The child's likely to be frightened, so it's really important that we are calm and, like I say, offer that reassurance so we can make sure the child feels comfortable and secure and know that they're being treated and being looked after. Okay, so the next thing we're going to look at is anaphylaxis. So anaphylaxis is a severe, life-threatening allergic reaction caused by an overreaction of the immune system. So common causes of anaphylaxis and allergic reactions are nuts, insect stings, seafood, prescribed drugs, but just about anything. And this is something we see quite commonly in our nurseries with children coming through with food allergies or allergies to things like penicillin. So we need to be really clear about how to recognise when a child's having an allergic reaction and also how to deal with that situation. So signs and symptoms of anaphylaxis and allergic reactions can include swelling. So that includes swelling of the mouth, the face, or any part of the body, but it can also include swelling of the airway, which is when it becomes very dangerous. They could have quite noisy breathing, So normal breathing is quite quiet. You don't often hear people's breaths, but if a child is starting to, or somebody's starting to make some quite noisy breaths, then that would not be normal breathing, and that would cause a concern for us. Their pulse could be quite weak, but could also be quite fast and quite rapid. They may be nauseous and they may be vomiting, or they may come out with blotchy, itchy skin and come out into hives. So I'm just going to show you some photos of some allergic reactions based on some of the things that people could have allergic reaction to. So can anybody guess what they think this person is having an allergic reaction to? Anybody want to hazard a guess what they think this person? You can either pop it in the chat box, or if you want to take yourself off mute, feel free to shout out. Very good guess, Eunice. Not quite dairy. It's actually somebody who's had an allergic reaction to nuts. So their lips are swollen and their face has started to swell. So this is somebody who's had an allergic reaction to nuts. What about this little boy here? What do we think this person's had an allergic reaction to? Yeah, it is penicillin. Yeah, well done. It's actually this. When I googled it, this was what somebody who's allergic to medication or penicillin happens. But absolutely, Chris, milk or dairy allergies could also, or any allergy could invoke this kind of allergic reaction, this kind of rash. But this one was penicillin. And what about this lady here? This one always gets people thinking it's hay fever or pollen.
Makeup or hair dye?
Absolutely, well done. It is hair dye. So this person hasn't done their patch test. So that's a lesson to us all to do our patch test before we dye our hair, so we don't come out in that reaction. And then the last one is quite faint, but people might be able to see it on the elbow. Anybody want to hazard a guess of what this might be?
Bite. A bite or a sting?
Yeah, absolutely. Yeah, absolutely. An insect bite. So the person's been bitten and they've come out with a bit of an allergic reaction. Spot on, Gemma, Eunice and Holly. You're all there. Brilliant. So with an allergic reaction, if they have a known allergic reaction, they do have what we call an autoinjector. Some of you may know it as an EpiPen, which is a brand of autoinjector. You would still call 999 and 112. So 112 is the equivalent of 999 in European areas. You would lie them down and raise their legs, because again we want to reduce that shock, and you would give that auto injector to that person, assisting them if needed. They might be able to administer it themselves, but if they can't, then you would need to administer it for them. If they have two available and the first one hasn't worked, then you can give a second dose of that auto injector, but the auto injector pen is a single dose medication. So once it's been used once, it can't be used again. It doesn't have any more than one dose in it. So you can only repeat that medication if they have a second pen available. But you just need to make sure you're prepared to resuscitate if needed. If they haven't been diagnosed with an allergic reaction or anaphylaxis before, and it's the first time they're having that reaction, it's really important that you call that 999 and the operator will advise you what to do while you're waiting for the paramedics to arrive. Okay, so finally, we're going to show you how to administer CPR to a baby and a child. So I'm just going to stop presenting my PowerPoint again, and I'm going to share my screen again to share the videos that Paul has created for us on how to administer that CPR to a baby and a child. Bear with me a sec. Yep. Sorry, Karen, you've gone very quiet. Was there a question? Sorry.
Yeah.
Is that in the thigh? Yes, Wendy. Yes, it's in the top quarter of their thigh. So I would stand up, but yeah, it's in the fleshy part of your thigh on the outside, and it's in a swift motion. What we do is we use the thing of sky to thigh. So you do it down in a swift motion from the sky into the thigh until you hear it click. And then you would hold it in place for 10 seconds to make sure the medicine goes through. And then you would then rub the area to make sure that medication has gone through. It does go through clothes, including jeans, so you don't need to remove any clothing to administer that auto-injector. Let me just share my screen and I will play those videos for you for the CPR.
Hi again. So we're going to do CPR for a child and for a baby. So CPR basically just mimics what the body would do naturally. Obviously, you're giving your breaths to get oxygen into the lungs and then obviously into the blood, and then you're doing your compressions to get the blood pumping around the body. So just a little acronym before we get started. We've got Dr. ABC. So this is the system we would always follow to do CPR. So the first thing is danger. So what's really important if you're in this emergency situation is you're assessing for danger before you go into any sort of first aid treatment, because the most important thing is not putting yourself in any danger, but also not putting the other person in any more risk of danger. So the dangers that you're kind of thinking about when you're at home or maybe at work and stuff, you've obviously got fire from cookers or from fires and things like that. You've got slips and spills, electricity, think about like ceiling tiles if you've got that type of ceiling at work and things. So yeah, danger. And I always say within danger, if you get into this situation, it's really important to call for help within there, because if you do end up having to do compressions, they are quite physically intensive, and you will probably only be able to do about 4 or 5 minutes. The next one we've got is response. So we're going to check for a response from the child, from the baby. And what we're going to do is we're going to use our voice first, and then we're going to ask them if they're okay. If you know their name, you'll call their name, ask them what's happened. So, are you okay? Are you okay? And then you're going to use a little bit of touch. So for a child or an adult, you would gently shake the shoulders or gently tap the shoulders, and that's how you get a response. So the person's either going to be alert and they're going to be able to respond to you and tell you what's happened. They may have a slight response, which is obviously troubling, or there may be no response at all. So you need to be trying to get on with that CPR as soon as possible. Then we've got airway. So what we would do is we would just check someone's airway and check that that's nice and open, things like that. And the way we would do that with a child is would use our hand and 2 fingers. So we do something called a head tilt, chin lift, which is exactly what it says on the we do head tilt, chin lift. The reason why we do that is just to make sure that the airway is nice and open, nice and smooth for when you're going to do your rescue breaths and things like that. Next one we've got is breathing, and this is where you're going to check for breathing. So we don't check for breathing for any longer than 10 seconds because we just want to get into that CPR treatment. It's really important to think about that the breathing just follows a pattern. Think of breathing like a heart. You know, a heart would normally go into a rhythmic pattern, so will breathing. So what I'm going to do is back to airway, my head tilt, chin lift, and then I'm going to check for breathing. So I'm going to move my ear to the person's mouth like this, and I'm going to check for 10 seconds. And what I'm doing there is I'm feeling for moisture, for expired air. I'm listening to the breathing sounds, and I'm watching the chest rise. And then the last one we've got is circulation. So we don't check people's pulses anymore or things like that, mainly because it's just so hard to do. And if you need to do a CPR, you need to do a CPR. So what we mean by circulation is if somebody's got a serious bleed, we would address that first, because obviously when you're going to do your compressions, the last thing you want is the blood to be not being around the body, basically. And we would also check for anaphylaxis, so check the airways and make sure that the person's not having a severe allergic reaction. Okay, so we've gone through Dr. ABC, so just some logistical things. So this is a child, so they are between 1 and puberty. I'm going to use 1 hand for my compressions, whereas an adult I would use 2 hands, and obviously because of bone density and things like that. And I'm going to start with rescue breaths. So for children and babies, we do 5 initial rescue breaths, whereas with adults, we go straight into compressions. And the reason for that is because 9 times out of 10, if you walk into an emergency situation, it's going to be an airway problem with children and babies, whereas with adults, it's probably going to be a cardiac problem. So what am I going to do? I'm going to do my head tilt, chin lift. I'm going to pinch the child's nose, and I'm going to make a seal with my mouth around that child's mouth. And what you've got to remember about your rescue breaths is it's a normal breath. I think people get a little bit panicked with it, but it's really just a... So people tend to maybe get a rush in that sort of situation. So I'm going to do my head tilt, chin lift, pinch the nose, make a seal, and when I'm doing my breath, I'm going to watch to see if the chest is rising to make sure it's effective. And then I'm going to go into my compressions. So like I said, we're going to use one hand, we're going to use the heel of our hand, and we're going to go right in between the chest like this. So it's really important that you are above the casualty and you're using, your arm is nice and straight, nice and locked in, and you do your compressions. So we're going to do 30 compressions, and the rate is 100 to 120 per minute, which is it's quite a lot. So we're going to do 30 compressions. So So 30 compressions, and then we'll go back into the breaths. So head tilt, chin lift, pinch the nose, make a seal, and you're going to do 2 breaths. And then we're going to do our compressions. So for a child and a baby, 5 rescue breaths, 30 compressions, 2 breaths, and then you just keep going, 32, 32, 32. And I guess the last thing I want to say before we move on to the baby is that if you're in a situation where you need to get some help, you need to get someone to support you, or you need to go and get your phone to ring 999, give 1 minute of CPR before you leave this casualty, because that's obviously just going to give them a nice bit of fresh oxygen and the blood moving around the body. So yeah, if you need to leave these people, we're going to do CPR for 1 minute. Thank you.
I'm just going to lastly show the video of CPR on a baby.
Hi again. So we're going to do CPR on a baby now. So I'm not going to go through the whole of the Dr. ABC again, but just so you can see it in practice. Checking for danger, making sure that the baby's not at further risk and I'm not putting myself at risk, looking for things like fire, electricity and things like that. I would probably call for help in here so that you can get someone to support you. Response for a baby, obviously we can talk to them, but we're looking for the response that they give really. Are they crying, are they gurgling, things like that. What you can do for a baby is tickle their feet. That's the best way to get a response from a baby. Airway, we're going to do our head tilt chin lift, but we're going to use 2 fingers for this rather than using our hand, and we're just going to be really, really gentle because obviously a baby's neck isn't as muscular and developed as a child or an adult. So 2 fingers for the airway, and then I'm going to check for breathing. So I'm going to check for breathing for 10 seconds. Again, I'm watching the chest rise, I'm listening for breathing sounds, and I'm feeling the moisture on my face, on my ear, sorry. Circulation, checking there's no serious bleeds, checking that we're not having an allergic reaction, and then we're going to do our CPR. So for a baby, again, the same as a child, 5 initial rescue breaths, and what you're going to want to do is make a seal over their mouth and their nose, because that's going to give you the best way to get a really good oxygen burst in there. Remember, babies only have little lungs, so obviously it's not going to be as much breath as we would for a child or an adult, so it's going to be maybe a rather than a... Yeah, so head tilt, chin lift, and I'm going to make the seal. And then I'm going to go into compression, so I'm going to use 2 fingers Again, in the middle of the chest, and we're going to do 30. So 30 compressions, and then we're going to do 2 breaths. So always remember, for a baby and a child, it's 5 to begin with, 30 compressions, then 2, and then you're just doing 32, 32. The depth is 1/3 of the chest, so that's the same for a child and a baby. 1/3 of the chest is the best depth that you could go for. There's lots of songs that you can sing to help you with the compressions. There's the famous Staying Alive by the Bee Gees, I think. You can use Baby Shark, which I know your parents will absolutely know that song. Or the one I always use is Row, Row, Row Your Boat, because if you sing that twice in your head, it's 30 compressions, basically. Okay, thank you. Hope that helps.
Thanks, Paul, for those videos. They were really, really thorough. So thank you for sharing those and creating those for us. So we're now going to answer any questions that have come through from the chat box, and please feel free to pop your hand up if you would like to ask any questions, or type into the chat box if you've got any questions for us. Have we had any come through so far, Karen?
Wendy's got her hand up, so she's got a question.
Yeah, hi Wendy.
Hi, thank you. Just a quick question. Yeah, I put my hand up when the child one was on. If it was a younger child, not a baby, would you still use the same force of breath, or would you use less depending on the age of the child?
Want to take that, Paul, or shall I?
Yeah, of course. I think it's just a kind of like using your own kind of like thinking about how big the child is, just thinking about how much breath you think they would normally take in. I think when what we talk about is like an effective breath. So when you're giving that breath, you're going to be watching the chest go up. So if you're giving a breath and you can see the chest rise, then that's effective. That's good.
Okay, thank you.
Please.
Claire, I've got a couple that came in from a couple of people that weren't able to make this session. I've got 2 questions and they link together actually from the one member. So they've asking, how long does it take to complete a paediatric first aid course? And once they've completed that, how long does that certificate last for?
Want to take that one for me?
Yeah, perfect. Thank you. So the pediatric first aid course is actually 12 hours. Sometimes can be delivered face to face. However, we use a blended learning approach. So we do 6 hours online with an online module, and then 6 hours face to face. And all the lovely London colleagues get me to deliver their first aid course. So that's nice. When we do the first aid, there are practical assessments. So both me observing, seeing if they can do CPR and choking recovery position, but also their peers. And there's like a quiz at the end of it as well. They've got to fill in to make sure that their competence and the knowledge is there. And how long does the certificate last for? 3 years. But like Eunice was talking about earlier, which was really amazing, the managers will ask first aid questions during the check-ins to make sure that information stays fresh. Because I know I've worked in childcare my whole life. You kind of go on this first aid training for a month, you're really positive and proactive, and then you start losing the information. So asking them questions at check-ins is perfect. It's really helped people remember the skills and knowledge.
Okay, Jules, you got a question?
I have. Thank you. Absolutely wonderful session, everybody. I've learned so much. Fantastic.
Yeah.
Nosebleeds. What's the best thing from? Because when I was young, there was different theories on what to do if a child has a nosebleed. You know, so yeah. Basically, what's the best course of action?
Yeah. So I've been in childcare possibly, well, definitely a lot longer than Paul, and I know the advice has changed over the years. It used to be to tilt your head back. That's absolutely not the advice currently, because if you tilt your head back, what happens is the blood will go down into your throat and you'll swallow it, and it'll actually cause the child or the person to vomit. So the advice for nosebleeds is to tilt the head forwards and to pinch the bridge of the nose, and to help again to form that clotting motion. That's what will stop the bleed from continuing. So it's always tilt the head forward and pinch the bridge of the nose quite tightly to form that clotting motion. If the bleeding hasn't stopped after about 30 minutes, you would need to phone for some support, get some medical treatment. But generally, if you pinch the bridge of the nose, keep the head tilted forward, it will stop the bleed.
Okay, Chris is asking a question about first aid with fits and seizures in children.
Yeah, so it's the same as what we were talking about with the febrile convulsions. So it's very making sure that the child is safe. So making sure that there's nothing they can harm themselves on. So moving any furniture or any hazards away from the child so they can have that seizure in a safe environment. Again, it's about protecting their head. So not holding on to their head, because that could cause further damage to the neck, but just having either some hands either side or a coat or some cushions, so as they're having the seizure, they have got something to bang their head against that's safe. It's timing the length of the seizure, because if it's goes on for any longer than 5 minutes, you would want to call for the paramedics. You would also call for the paramedics if it's the first time the child has ever had a seizure, or if they are having repeated seizures. So that's where they have a seizure, it stops, they then go into another seizure, it stops, they then go into another seizure. You would also want to call a paramedic at that point. You just need to let the seizure run naturally. It will stop, but what you would need to do is, once the child has had that seizure, you would just need to monitor their airway and check that their airway isn't blocked. As we've said at the beginning of the session about choking, children put a lot of things in their mouth. So if they have the seizure while they're eating, or if they've got a boiled sweet or chewing gum or something in their mouth, then that seizure could have caused that airway to be blocked. So again, it's going back to treating the situation. So if the airway is blocked, we need to clear that airway, and you would just need to be prepared to resuscitate if needed. Most people who have a seizure, they do come round from them quite quickly, and they're likely to be quite tired after they've had a seizure, so they will want to have a rest or have a sleep. Some children and adults may also urinate during a seizure, because they do lose control of their bodily fluids. So it's making sure that you're covering them up to keep that dignity for them, and changing the child once they've come out of the seizure. Hope that helps, Chris.
I've got another question that came in. It says, if a child gets a wound and it has an objects embedded in it, should you remove them?
Paul, do you want to take that one?
Yeah, perfect. Thank you. I do get asked this quite often, actually, in first aid training. So, if it was like a splinter and things like that, obviously you can remove splinters, but anything bigger than that, I really wouldn't recommend removing at all. Because what could happen is, if you remove it, you could cause further damage by pulling it out in the wrong direction or an opposite direction, and it's stemming the bleeding. So the bleeding could get worse. What I suggest to colleagues when we do the training is using sterile bandaging to bandage around the object and keep it nice and secure, because not only will the bandages keep the pressure on the wound, but keeping that object secure, and so it's not going to move or anything. And yeah, if a child has stuck anything in their nose, ear, or any other orifice, which I know happens all the time, don't attempt to remove it. Definitely take the child to hospital, where the professionals can remove it safely.
Right, thanks. Chris is asking a question. Should children be allowed to sleep after a fall?
Yeah, so again, this is probably where advice has changed over the years. So where children had concussion and had quite a nasty bump to the head, we were always told to keep them awake and don't let them go to sleep. That advice has now changed. You can let the children go to sleep, because sleep actually is a good healer. But what we would recommend is you monitor that child regularly, making sure that you're checking their airway and their breathing and that the situation hasn't got worse. So it's absolutely fine for them to go to sleep, but I wouldn't leave them unattended for any long period of time, and just keep gradually, carefully monitoring them to make sure they are still breathing and their situation hasn't got worse.
And Eunice, you've got your hand up.
Yes, just to follow on what Claire was saying, when I did my last first aid, the trainer was saying that also need to make sure that if it's a normal time, sleep time for the child, then of course to let the child sleep. If it falls asleep at a random time, then that should raise concern. So just also to know the child and their routine to assess whether it's normal for them to sleep at that time or it's because of that fall that is causing the child to go.
Brilliant, thanks, Eunice.
Right, I'm conscious of time now, everybody, because we've gone over 5 minutes, but we've had some really good questions there. So
feel free, if you've got any further questions, I'll pop my email address in the chat box. If you do have any further questions after the session, feel free to drop me a message and we'll continue to answer them after today's session as well. I know we've got a survey link that we're going to pop into the chat. I'm just going to ask you to complete this short feedback form for us by clicking on the link. It shouldn't take any more than a couple of minutes to complete. So Karen's just popped that in the chat box for us. So if you could just take a couple of minutes to complete that for us to get that feedback, that would be really fantastic. And while you're doing that, I'm just going to share the slideshow very quickly to share the last slide. Go to the end. So it's just to say thank you everybody for attending this evening and for being so engaged and asking lots of questions. It's been really lovely to spend this evening with you. I hope you found it enjoyable and informative, and we hope to see you at our AGM on the 14th of May. For the first time in 2 years, it is going to be face-to-face and a hybrid event, so we do hope to see many of you face-to-face at the Motorcycle Museum on the 14th of May. To find out more and to book your place, you just need to visit mid.coops/AGM for you to be able to book your place. I'm going to stop presenting and say thank you everybody for joining. The video will be going up onto our website so you can watch back on a later date. And thank you very much. And thank you to Paul and to Eunice for joining us this evening as well.
Yeah, thanks everybody. And yeah, if you wouldn't mind just taking a couple of minutes now that we've finished just to do our feedback form, we'd be really grateful, because we can only grow, and that when we know if we're doing a good job or what it is you guys would like to see and that. So really appreciate it if you wouldn't mind just taking a couple of minutes just to click on that link and do the feedback for us. Thanks ever so much for everybody that's taken the time of their evening to join us tonight, and thanks to the guys that have presented. I think you've done a really brilliant job. Thank you. Well done.